Nick?
Yeah, sure. Hi, everyone. My name is Nicholas Franco, and I'm a coordinator of this group with Dr. Anita Chopra. And we have a fantastic guest today, and I will let Dr. Chopra introduce her.
Thank you, Nick. Welcome to the ACP Long COVID webinar series. And today I'm just, uh, you know, uh, so very excited because I have someone as guest who I really look up to. And I'm honored and delighted to welcome our guest today. She's a trailblazer in medicine, a research scientist who strives to understand the rare and unknown conditions in medicine, which is really exciting. A clinician with a focus on care for patients with complex illnesses. She's a teacher and a mentor. Dr. Linda Geng is Clinical Associate Professor of Medicine, Primary Care and Population Health, and co-director for the Stanford Long COVID Collaborative. Welcome, Linda.
Thank you so much for your kind introduction. It's such a pleasure and privilege to be here.
Linda, you wear so many hats and you've played so many different roles in the long COVID arena, and you've worked with government agencies. How has your dual role, the role as a physician and a scientist, shaped your diagnostic approach to long COVID, especially in primary care settings? Most of the audience here today are primary care physicians. We have limited time and limited tools. So, what has been your diagnostic approach?
Yeah, thanks so much. And just to give a little bit more background, before the pandemic, what my focus was on complex and puzzling conditions and rare conditions. So I used to run a diagnostic second opinion clinic with other internists as well in a multidisciplinary approach, which of course, as you can think about for long COVID, that's definitely what's needed. And when we ran that, it was called consultative medicine. And it's what you think about, when you have like a puzzling case or somebody in seeing in primary care or in other specialties, and maybe seeing several physicians and still doesn't either have a clear diagnosis or maybe multiple diagnoses that just doesn't seem to come together or it's unknown. And so typically these end up being rare or complex or multi-system or novel conditions. And when we carefully reviewed their illness histories from this clinic, about 1 in 5 of those patients we saw in this, again, a very general all comers diagnostic clinic, 1 in 5, like 20% about, had an infection, if you look at their history, that preceded the start of their typically spiraling health journey. And so these post-viral or post-infectious conditions are actually quite common, especially in primary care, but also, of course, throughout healthcare that we see, but are poorly understood and end up then, kind of going through our fragmented healthcare system. And sometimes it can be very difficult, especially in primary care where we're really busy, have limited time to diagnose and get the patient to the right care. Because of my interest in this, we often also had overlap in conditions where other specialists like Dr. Bonilla and Hector Bonilla, I think he was also one of the speakers previously. I reached out to him and we came together and said, hey, we see a lot of these patients. And after COVID, we recognized that there were a lot of patients who had lingering puzzling symptoms and conditions as well after that infection. So this was all happening, before the pandemic, but of course it was recognized very clearly that COVID is yet another virus that can lead to these post-infectious syndromes. And if we can recognize and diagnose these syndromes earlier in the patient's journey, we can hopefully get the patients to the right care sooner and potentially even prevent or mitigate that downward spiraling, health journey and the inefficiency and burden of bouncing around from doctor to doctor.
So, Linda, I really appreciate what you said, but I also want to, just for our audience here, one thing that you've always talked about is pattern recognition and, just keeping that keen eye. And I know that we will talk about this, further in this podcast or webinar, but I really think that, for example, before the long COVID, before I started seeing long COVID patients, I never had this, uh, in my mind to look for these patterns. I never, even thought of looking for them. But now that I have been seeing patients, I now recognize certain patterns which I would have completely ignored. So, Nick, over to you for the next question.
Sure. So kind of in that vein, are there any kind of distinguishing features or specific features of long COVID that help you kind of in your differential diagnosis of looking at kind of post viral illnesses?
Yeah, great question. I mean, this brings up the whole idea of the bigger umbrella of post-viral syndromes, or also infection-associated chronic conditions, which is another term to encapsulate this umbrella. Again, COVID is not the only virus, right? Other viruses, influenza, EBV, chikungunya, dengue, etc. The list goes on of infections, including viruses, bacteria, and others that can cause post-infectious syndromes or infection-associated chronic conditions. And there's a lot of overlap sometimes in the clinical manifestations of these infection-associated or IACCs, chronic conditions. In terms of, like what would be big pattern recognition, or how can you screen? Like, for example, we really need a good screening tool. If we go by the 2024 NASEM definition, National Academies, where they define long COVID as an infection-associated chronic condition that lasts, 3 months or longer after the COVID infection. And it can be multi-system. And as we know, the pattern of the illness trajectory can be either progressive or it can be relapsing, remitting. But I think some of that key we can take away, and we can then think and apply clinically and just ask yourself 2 questions. Was there an infection? What was that infection? Was it COVID or some other infection? And then was there a change in health status pre and post? And sometimes when you look back at a patient's history, it's really clear, that time frame, they had an infection or infections, sometimes it's multiple. And then that event, that immune activating event afterwards, they started developing all these things, or after that, they still had persistent symptoms. So in terms of if you wanted a 2-question screener, you could ask yourself that, what is that preceding infection? And then 2, was there a change in health status, either lingering symptoms for their initial infection or a worsening or new health conditions that developed? But this could be applied for other infections too. It's not COVID specific, but it gets you started thinking about it. And then I would say, some of the big 5 phenotypes, but it's a really comprehensive big list, right, of lots of symptoms and syndromes that can manifest. But some of the most common, so like the big 5 to recognize, are exertional intolerance. That could be due to fatigue, post-exertional malaise, dyspnea, other symptoms, brain fog, sort of the cognitive bucket, as well as sleep issues, pain syndromes, musculoskeletal aches, body aches, neuropathic pain, as well as autonomic dysfunction or dysautonomia, for example, POTS, orthostatic issues. And so if you think about these big 5 buckets, it starts to help with pattern recognition. They can definitely happen with long COVID, but they can also happen with other viruses. So I think my point here is that it's hard to tease some of these apart. And I have had patients who had COVID and mono and flu, and sometimes it's hard to tease apart which one led to these symptoms or conditions. And I've also had patients later on in their journey, maybe they had long COVID and they got better, and then they came back to see me because they had a whole slew of infections during the wintertime. It was influenza, it was something else that wasn't tested, plus COVID, and so they flared up again. And that's also another pattern we can see, that other infections can then subsequently trigger, essentially almost like a susceptibility or relapse in some of these people. In our group, we have studied, of course, along with Dr. Hector Bonilla, who's an expert in ME/CFS. We found that about 50%, which is consistent with the literature, half of our patients have an ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome phenotype, again, encapsulating some of those big 5 symptom buckets, as well as autonomic dysfunction. And also there were a large EHR study that showed post-influenza during the pandemic of people having very similar symptoms as long COVID, as post-COVID. So there's definitely overlap in these symptoms.
I think what you said is so fantastic, is immune activating event. I think that, by default now, if someone comes to me complaining of chronic fatigue, I go back and ask them if there was a triggering event, if there was an infection, or did it coincide with COVID. A lot of times, I'm amazed that there is like a 3 or 4 month prior history of COVID, and then they are coming in with these symptoms, and then patients start fitting into patterns. And I know that, Hector Bunia is on the call today as well. And I know that he has spoken in the past about the pathobiology, and he's very passionate about this and the involvement of, mitochondrial damage and such. I'm not going to, tease that a whole lot, but I think that it's fascinating how this happens and what is the mechanism behind it. So Linda, for this, for our group today, we really we struggle as primary care physicians as to what clinical decision-making tools can be used to diagnose these patients. And what are some of the PROs, the patient-reported outcomes that you use? So what are some of the tips that you can give us as primary care docs before we are referring out to specialists? What can we do in our clinic?
Yeah, it goes back to the NASM definition and the phenotypes, because we still right now lack concrete diagnostic criteria, right? We haven't reached like a consensus beyond the NASM definition, which is more broad, which is good. It can help patients access services, but in terms of granularity, right now it's still a lot of research-based, clustering and phenotype characterization, but there hasn't been a clinical guidance on specific diagnostic criteria, aside from this kind of screening parameters that I mentioned. And then we're also lacking really concrete, validated, specific diagnostic biomarkers, which is another urgent, kind of holy grail that we would really benefit from in having the field, so we could both diagnose more accurately as well as monitor treatments and prognosis. But so all that to say, it's still a clinical judgment, right? It's still clinical diagnosis, and we need to be able to recognize the patterns, such as the big five, in addition to the variability, understanding it's not just the big five, but there's other symptoms and syndromes under that large umbrella. I think of it almost like, headaches. Like, we have an international classification system for headache disorders. You have primary headache disorders, secondary, you have different migraine subtypes. I think of it very similar, analogous. And we may not have a biomarker yet, but in headache field, there's treatments that are done, and it's based on phenotypic kind of subtypes, and you can then treat and tailor your treatment. And I think of it very similar, because otherwise it gets too overwhelming. And I hear a lot of, primary care colleagues of mine as well say, well, it's not defined, it's too murky, it's poorly understood, so I'm not gonna, not gonna look for, not gonna diagnose it, and also there's nothing we can do about it. And I would argue that those aren't completely true, all three of those types of thoughts, because we can start to classify, as part of the Recover Initiative, we did from a perspective 14,000 participant study longitudinally. We also assessed their symptoms, and we could cluster very clearly 5 groups of phenotypes. In addition to this like overlapping syndromes that we talked about, including ME/CFS and POTS and other post-viral syndromes, we can start to get a sense, as well as the big 5 bucket of symptoms, what to look out for, what to screen for. And then also, we can leverage the knowledge about these overlapping syndromes and other post-viral conditions to think about treatment, and as well as what you mentioned very nicely about the pathobiology and some of the agents that might be used to treat some of these conditions. And one other big bucket would be GI, actually, because I think about, the broader umbrella of post-infectious syndromes, or IACCs. And another common story that I hear too in primary care too is somebody going on a trip or traveling, getting traveler's diarrhea, and then coming back and their whole GI system is awry, and it's just in disarray, and they have other multi-system symptoms as well. So that's another type of phenotype, and it doesn't have to be COVID, but it could be. COVID can also lead to gastrointestinal symptoms. So you can see the myriad of things, but I think the key is to really look at the history and pay attention to, potential, or ask about potential infections that preceded this spiral of complex symptoms.
Great, thank you. That's a really, really thorough answer. And yeah, I think the big 5 are definitely key to look out for. In terms of fatigue and cognitive dysfunction, what kind of treatment strategies or care models have shown the most promise for these kind of phenotypes or conditions, especially in community-based practice?
Yeah, great question. And this sort of brings the broader topic of management. And I think I just want to underscore, as of today, there's still no FDA-approved therapies to treat long COVID. So that's a huge need. Having said that, management, of course, can't wait. We need to move and make progress while we're trying to search for that, a safe, effective, evidence, proven therapy. Management is typically very individually tailored, as you can imagine, because long COVID is so heterogeneous, right? One person's long COVID isn't necessarily the same as the next person's long COVID. Even fatigue is a big, broad category under that, where somebody could have fatigue but really have post-exertional malaise, worsening symptoms with exertion, and somebody else may benefit from exercise. So you really have to pay attention to what the patient is telling you. And of course, as we tell the patient, you have to listen to what your body is telling you. And the patients are the expert, right, in their body and their experience and their lived experience. So marrying that with understanding post-viral syndromes in general can help treatment strategies, but this still needs to be studied with randomized controlled trials. There's a variety of interventions, both pharmacologic and non-pharmacologic, that could be potentially used to treat. And some are experimental, be done maybe either part of clinical trials or as part of an individual clinician to patient encounter in an off-label way if it's repurposed medication. And I would say that at this time, generally, and I think this is pretty consistent across different clinics, we take a whole person and multimodal approach, right? That includes for very non-specific symptoms like fatigue and cognitive deficits, where first you want to evaluate for a lot of contributing factors that could be exacerbating or like worsening, along with just the umbrella of long COVID. That includes, for example, sleep disorders, endocrine abnormalities, nutrient deficits, etc. And then you want to address lifestyle, diet changes, maybe that could be beneficial. Again, this needs to be studied deeper, but for example, pacing and anti-inflammatory foods, because one of the leading models is that a lot of the common pathways in post-viral syndrome, including long COVID, lead to chronic inflammatory abnormalities and dysregulation. And then rehabilitation approaches to support, including supportive care, and then potentially pharmaceutical approaches, like I mentioned, but again, tailored to the individual.
Yeah, I think that one of the things that our patients, we try to reiterate it, and they come to us in the long COVID clinic, and they feel that there will be some one magic cure, which is not
Yes.
there. But there are
Yeah.
these different modalities, different
Mhm.
strategies that we can use to, in their journey towards recovery. And you mentioned non-pharmacological and pharmacological. Of course, we don't have any FDA-approved treatments, but we rely a lot on non-pharmacological strategies. And one of those strategies is pacing and,
Mhm.
rehabilitation as well. So this is useful in fatigue and in brain fog, cognitive, changes as well. Linda, what is the role of rehabilitation and pacing that, in your practice? How do you use it? And what are some of the specialists or providers that you refer to for that,
Yes,
just for
yes,
this?
yeah,
Yeah.
that's such a great question. And I really value our partnerships with our rehabilitation colleagues, for example, with speech therapy, occupational therapy, and also physical therapy, especially those who have experience with infection-associated chronic conditions or MECFS, POTS, those overlap syndromes, and are familiar with patients who may have post-exertional malaise and know how to tailor programs for individuals who suffer from that. So I think, yeah, it's a great benefit. And some patients really feel like they have support, additional support. They have something they can help control. Like, it's like you feel like a lot of these patients, they feel like they've lost control. Their body, you can't trust their body. It's not who they are. And they don't know if there's anything they can do, especially now that we don't have an FDA-approved therapy. And just like you said, there's not a one size fits all. There's not a magical pill. And I often tell patients, even if it's not, there's a lot of things we can still do within our control, and we can try our best. And it takes multimodal, right? Like we don't just look for that one magic pill. We're going to try to address it from every angle possible. And that includes lifestyle support, rehabilitation support. And it tailors to the individual. Some people may benefit from a more comprehensive and intensive program if that's what they can do and are benefit from. But it's really important for others to take it very easy for pacing, and it can look very different for different people. There's some people who can't get out of bed, but for others, they can go for a walk, they can do exercises, they can do cognitive intensive activities, they do play the brain games and other things. They do the mindfulness meditation plus, XYZ. But there's others who really need to dial it down, so that it needs to be tailored to their energy window and capabilities, and their whether or not they have post-exertional malaise. We actually have, I'll put a plug in for our, we are trying to create a lot of, as you all are, of course, and others around the country are trying to create resources and tools for primary care clinicians and other out there, as well as patients. And so on our website, we have a program at Stanford called Long COVID Care Reach as part of the AHRQ National Network. And we created patient self-care videos to talk about brain fog and pacing, and as well as dietary approaches, sleep, and some of these smell loss, taste loss. And so we really hope that this can be a resource so that clinicians can give this to their patients, and they're really short, they're aimed at the public, and they can go through this in a way that can be applied at home, and so it doesn't involve necessarily a prescription, but something that patients can do within their control. So I definitely think that these resources are becoming more and more helpful and utilized so that patients can do things to help with their symptoms that's not just pharmacologic.
Thank you so much, Linda, for this. I think that it's so important for us to understand that it is like a Venn diagram. The fatigue, the brain fog or cognitive changes, and the dysautonomia. And they can have overlapping symptoms, like a mix and match of symptoms, and
That's right.
one thing can influence the other.
That's right.
Fatigue and brain fog or cognitive changes can go hand in hand. And sometimes patients are actually so tired that they also feel like they are not thinking clearly. And if
Mm-hmm.
they are pushing themselves and crashing, the fatigue and brain fog are, going hand in hand. Linda, there is a question in the chat, and also I would love for you to please talk about this specific to brain fog, because that is, I have seen patients in my practice who are CEOs or CFOs of
Mm-hmm.
companies, and now they are having trouble with sequential thinking, with the, with retaining information or recall. What are some non-pharmacological measures that you use for these patients with brain fog?
Sure, non-pharmacologic. So non-pharmacologic approaches, again, still goes back to the whole person approach, but particularly for brain fog, identifying any reversible causes, right? Making sure that they're not deficient in any nutrients, for example, B vitamins, et cetera. And also making sure that they're asleep, right? You start to think about the other buckets too that could be contributing to brain fog. And I actually had a patient who post-COVID had really significant symptoms of fatigue, brain fog, the whole, kind of cluster of symptoms that typically go together. And then it turns out they had really severe sleep apnea that wasn't treated. And then that was treated, and they actually felt a lot better. And it wasn't pharmacologic intervention at all. It was a CPAP. So I think that's always important. I mean, that's actually general primary care. You start to think about the differential for non-specific symptoms and address and treat what underlying causes there might be. And under the umbrella of long COVID, we're still trying to understand how sleep can change, because a lot of people have new onset, either hypersomnia or insomnia. And again, those exacerbate all those other symptoms of fatigue, daytime fatigue, and brain fog, and these issues. It's also important to think about habits. We published a case series about people who really clearly had worsening symptoms after alcohol intake. And so just thinking about recreational substances as well, what could be exacerbating in addition to lifestyle modifications. Mindfulness meditation has been really helpful for some. And then as we think about pharmacologic strategies, we think about the categories of repurposed drugs that could be tested or used. Our group, has also published on a retrospective analysis of our experience with things like low-dose naltrexone. Again, this needs rigorous placebo-controlled clinical trial, but I think this is really encouraging, and it's a candidate and it should be considered and studied further. So there's lots to explore, right? Under immune modulators, antihistamines, neurologic agents, and other agents. But there's a lot of avenues, and I want to, you know, again, kind of address that myth, if you will, or misperception in some of my primary care circles, where people feel like, well, there's not much we can do, but people can respond to some of these. We need more evidence for sure, uh, but there's strategies, both non-pharmacologic as well as potentially off-label therapies.
Great. And actually, on that topic, as kind of evidence grows, but there's maybe a lack of formal FDA approval for specific pharmacological treatments. How do you go into those conversations with your patients about risk benefit, and kind of how do you tailor it specifically to this situation?
Yes, and this is a really important area, right? We're sort of in like the frontiers of medicine, where there is, you need to make progress and there's a lot of patients in need, but at the same time, you have to be careful balancing risk and benefit while pushing the boundaries so that we can make progress. And that's really, and also, of course, patient-centered care and their preferences, their own, needs, and what they're, there are some people who really don't want to try an experimental therapy, and others are coming to you with a dozen different ones that they found on the internet. So you really have to think about, for the person who's in front of you, what are their personal preferences, as well as risk, we don't know a lot about the potential benefits aside from the anecdotal and mostly retrospective data as at this point. And while we're, of course, trying to leverage that, we do also have, for some drugs, for some repurposed older drugs, we do have quite a bit of safety data. So, we know some of these, for example, low-dose naltrexone or antihistamines, they're over the counter. I mean, their safety profile is well known. And so you can lean more towards understanding the safety profile and understanding the risks, and then say, there's potential benefit. And then as you're doing trial and error, just being transparent and having patients who are informed in that shared decision making is really important. But hopefully the evidence will catch up and we can make more evidence informed decisions.
So, Linda, you spoke about repurposed drugs, and actually, your center has been pioneering some of the studies, and you guys have trials going on as well. And there are some of these medications, like you said, which have safety data available, have been shown to be of benefit for some patients. You talked about antihistaminics, especially with patients. We tend to use them with patients with MCAS, mast cell activation type of symptoms. And then you talked about low dose naltrexone. I know that we need to really tailor, to the patient's specific needs. But what would prompt you, and I have spoken about this with Hector as well, to consider low dose naltrexone in a patient? What would prompt you? And again, with the caveat that it's not FDA approved, this is an experimental, medication. Uh, where would you think it might work?
Yeah, that's a great question. So, and this is where repurposed drug are great because their safety profile, and there's been typically, especially with low-dose naltrexone, decades of data out in the literature about its use in other conditions too, which I think is a strength of some of these candidates. I'm not just saying low-dose naltrexone. I think I'm biased. I learned from the great Dr. Benia, and who has used this in chronic fatigue syndrome, but also there's a lot of literature for its use in other inflammatory autoimmune conditions such as fatigue and multiple sclerosis, inflammatory bowel disease, fibromyalgia. Actually, the list goes on and on. It's being tried in cancer and HIV, lots of different conditions. And that's because it's a gentle immunomodulating, agent that has been utilized and has, at least in some of these studies, found to be beneficial for some patients. The challenge with repurposed drugs, especially when they're generic, is that there's typically, it's difficult to get the funding support and sort of the commercial interest to be able to run huge trials that are really needed to then have that final pivotal, evidence base to make these kind of guidelines. However, I think when you have multiple groups in different areas, I believe like our group, has found some retrospective anecdotal benefit, and then there's a group in Ireland, there's a group in Canada running a trial. So when you start to accumulate collective, although albeit not this large pivotal RCT, but you're starting to build these evidence pockets, then it starts to collate together, and it becomes more and more encouraging, and also provides further rationale for running that pivotal trial. And I think about it then in the setting of leveraging its knowledge and use in other conditions. So for somebody who has a phenotype of fibromyalgia, if they have a lot of musculoskeletal pain, there's been a review paper about low-dose naltrexone as an anti-inflammatory, and for specifically pain, chronic pain conditions, including in, for example, non-inflammatory conditions that, non-rheumatologic conditions that, for example, reminiscent of fibromyalgia or other diffuse body pain syndromes in that phenotype, but also, as I mentioned, ME/CFS and potentially others. And right now, it's being studied as well, and thought to be potentially useful in autonomic phenotypes as well. But it's more evidence needs to be developed there. And I will say, so, there's sort of two big categories of treatment or management. One is symptom-based, right? You're just trying to get somebody feeling better. That could be supportive care. That could be even pharmacologic agents that address really a symptom, like, for example, some stimulants or other kind of ADHD type medications that are being repurposed for cognitive symptoms. Unless there's a mechanistic rationale or hypothesis that really drives, the mechanistic pathway, it's really aimed at just the symptom treatment. On the other hand, something like low-dose naltrexone, you're trying to address underlying pathophysiology, the chronic inflammation that's occurring, and potentially, other agents too that address either microbiome or mitochondria or neurological pathways or viral pathways. For example, we ran a clinical trial testing Paxlovid for 15 days because, again, one of the leading hypotheses was, is there remnant pieces of the virus or a persistent viral reservoir that could be leading to symptoms in people with long COVID? That trial didn't find benefit for that select population at 10 weeks for 6 common symptoms, but there are several other trials that are underway, and there's a big one from the Recover Initiative with many more participants. So we're really curious to see. And so this is just the first step in testing and the need for evidence for a lot of different therapies.
I'm so glad, Linda, that you mentioned your Paxlovid study, because that actually will form the basis of perhaps many other studies as well. But the fact that you guys did not find benefit with prolonged Paxlovid therapy in that particular population, perhaps it's important to remember that. And thank you for, giving us so much information about low dose naltrexone. I think you guys have that vantage point because you have a dedicated ME/CFS clinic as well, and you are seeing chronic fatigue patients. And of course, Hector, has used low dose naltrexone in his chronic fatigue patients, ME/CFS patients with benefit. And I know that he has another trial coming up with where he is using Abilify in these patients, and perhaps we can talk about it at another time. But I would love to know, Linda, what other trials are you involved in this sphere?
Oh, sure. So Recover Initiative has some of the biggest, platform trials and different trials for different phenotypes right now. And then there should be another, hopefully, to launch soon, the second phase of the trials called Recover TLC, or Treating Long COVID. And so I'm excited to see, hopefully, what agents will be chosen for that next round of trials. And then currently and previously part of the original phrase of the clinical trials under Recover, we were running trials testing, for example, transcranial direct current stimulation, as well as brain HQ and other interventions for brain fog. There's a trial we're running right now testing ivabradine, and other sites are testing potentially IVIG for the POTS phenotype. There's another trial running right now for exercise intolerance and sleep. So there's lots of trials underway. And I know there's nationally also trials testing other anti-inflammatory agents. And of course, there's tons of trials that are registered. So this is definitely not comprehensive by any means. But I think the big categories that are, I'm really interested to see are those anti-inflammatory agents, immune modulators, potentially neurological agents, cardiovascular agents, as well as, again, non-pharmacologic strategies, and possibly, combining some of these therapies may be also the ultimate answer.
One thing before Nick, you go to the next question, I just want to highlight for our listeners here that the microbiome that you mentioned, there is evidence of dysbiosis, where which brings to the spotlight probiotics. So I think that is something that we often perhaps overlook or get dismissed. But I just want to underline that is that the benefit of anti-inflammatory diet, the benefit of probiotics. So Nick, over to you for the next question.
Yeah, so we had a question in the chat kind of about waxing and waning symptoms. And I was wondering if you could talk a little bit about kind of what your management strategies are for those folks, and kind of talk a little about what I think patients commonly refer to as crashing.
Yeah, this is great. A great question. And there is some literature as well, some qualitative and descriptive studies about patients' trajectories, but this definitely needs more investigation just in terms of the different patterns. It is recognized that similar to some of the other infection-associated chronic conditions and autoimmune conditions as well, for example, multiple sclerosis or other rheumatologic conditions, that people can have periods of remission or quiescence, if you will, or better days, as patients will put it, or better weeks, better months. And then there's going to be bad days, bad weeks, bad periods. And sometimes patients don't, like when I ask them, what could have set this off? Can we think back to you were doing really well and then, something happened? Sometimes it's not clear. Sometimes it's very clear. They had a reinfection. Maybe it's COVID, or they had another infection. Maybe it was flu, maybe it was mono, something else set it off. So to the question, what other triggers besides infections, sometimes it can be a life event. So, we think about immune activating events, and it doesn't have to be an infection. It could be an injury. It could be, for example, somebody had a car accident, they're in the hospital, or they had surgery. Something sets off an inflammatory response or an immune response or a stress response. And patients will often report that something major happened in their life, or something that triggered an immune activation or inflammatory response or a major stress response.
Yeah, I loved what you said about, and you earlier talked about post-exertional malaise and just this fatigue, which is triggered fatigue. And the trigger can be anything. It can be physical exertion or cognitive burden or environmental burden or just mental stress, or any of those can be triggers for these patients. Um, Linda, we are drawing to towards the end of it, the webinar, and I invite other questions that our audience may have. But what are some of the tips that you would like to give to our primary care physicians? You being an internist yourself, what are some of the things that you would just highlight for primary care physicians who are struggling with this, who have these patients, and we sometimes don't know which which path to follow or what diagnostic decision making to follow. So what are some of the tips, that bullet points that you would give us?
Yeah, thanks so much. And I want to say, I'm representing a collective village, including yourself and Dr. Vinny on this call and others who are working in this area. I'm so lucky and privileged to be, part of this collective village along with amazing colleagues like yourself. So I think there's a lot of resources out there. So first of all, I want to point people and say, to these tools and resources that we're creating as well as others, and large consortia and expert consensus statements. For example, from AAPM&R, there's a huge compendium of lots of tables in terms of guidance on symptoms, diagnosis, treatment strategies, as well as there's a Canadian group as well that came out with a lot of detailed guidance on a lot of deep resources. We have CME that's recorded from last year, as well as we're running another one, if I can put in a plug, and on May 29th. Everybody's welcome, it's free. And I know you all run them and others across the national network. So we're all here for each other to support and empower primary care, but all clinicians. And I think the other, main point to not get overwhelmed, because I felt the same as well. When I was running the diagnostic clinic, and you'd have a huge chart. The patient has seen a dozen doctors, and nobody's clear, like what is going on. And I think sometimes you just need to parse it down. It doesn't have to be, can I figure out if it was mono or if it was flu or COVID? What if they had a test or did they not have it? And sometimes it's simpler just to say, did they have an infection? Did their health status change? If you just think of those two symptoms, and you can start to build this concept of this large umbrella of IACCs, infection-associated chronic conditions. And sometimes, at least at this point, until we get more granular evidence about how to do these different pathways, a lot of these are shared strategies. So be it post-mono or post-flu or post-COVID, if they have fatigue and post-exertional malaise and brain fog and these overlapping kind of big 5 buckets plus other buckets as well, you can start to try some of these strategies, right, in terms of management. And also, even if you start to think about them having a post-infectious condition or infection-associated chronic condition, you can also get them to the right care. Maybe consider referring to a specialized long COVID center or clinic or MECFS place, or there's autonomic clinics as well around the country. So being able to recognize these patterns and thinking in the history or bringing out that history of the infection that was a pivotal turning point can get the ball rolling. And you can enlist help from specialists who have familiarity and are working on these areas. But I think we can do a lot in primary care, and it's where it's most important, because we're trying to diagnose people to get them to the right further care and help prevent that spiral of health issues that tend to happen with patients if they have prolonged under recognition of, and also let's not forget too, the validation of patients, right? A lot of people go through the healthcare system. Nobody has recognized that they have an infection-associated chronic condition or long COVID or MECFS. And then, they run tests and it looks normal, quote unquote normal, but really they're feeling and suffering inside. And then there's a disconnect with their providers. There's dismissal and invalidation, and it leads to secondary issues that then further erode that therapeutic relationship. So hopefully if we catch it earlier on and we can start validating and providing some of these supportive care in addition to getting them, potentially additional therapies. And as we do research, if they're interested to participate, we can make a lot of progress as well.
I think what you said is so important about the patients being dismissed, and I think it also has the other collateral effect it has is multiple ER visits and urgent care visits and the cost to healthcare. Couple of takeaway points that I took from your conversation is I think that long COVID is probably a primary care, falls in the primary care sort of in our realm. It's something that we need to learn to manage. The other thing that I really appreciate is that the fact that there is not one good treatment, but there are different strategies that we need to, to use. But most of all, what was the most valuable, what you said is pattern recognition, is the 5 buckets. I think that is a very important takeaway point for all of us. And thank you very much, Linda, for your time today, for giving us your perspective, for the work that you are doing, your commitment to medical mysteries. I always say that you are someone who is dedicated and passionate about medical mysteries, and we need people like you. Thank you for bringing this hope and clarity to us and to our primary care physicians. And I echo all of us on this call that we are grateful for your expertise. So thank you very much.
Thank you so much. It's a privilege and a pleasure. Like I said, I'm working as part of a collective village, including with the amazing Dr. Vania, as well as Dr. Chopra yourself and Nick, incredible student team. I see Tom on this call, so that's great. We have an incredible research team and clinical team and all of our staff. So I think I just want to reemphasize that it takes a collective village. It is a challenging problem in medicine. It's been historically neglected, but and Anita, I've said this before, but medical mysteries can be solved, right? Other conditions were puzzling in the past, 100 years ago, and then we have treatments and we have understanding of their biomechanisms now, and we need to do the same. Legitimize the condition, take it seriously. It's here to stay. There's going to be another pandemic. Infection-associated chronic conditions were here before, and they will be here. And we need to figure out answers for our patients, and we can do that as a collective village. Thank you so much.
Thank you. And I want to put in a plug for, your CME from Stanford, where you can
Thanks.
catch Dr. Geng and Dr. Bunia, and they will be sharing their work as well. So I invite you guys to and encourage you guys to please sign up for that CME. It's free and it's virtual, so might as well, avail of that opportunity.
Thanks so much.
Thank you.
I'll put in one last plug, and that's I'll send out a recording. So if you want to share or view any of our previous sessions or this one again, they are all uploaded on our YouTube channel, and so you can check them out there. Thanks so much, everyone.
Thank you. And Nick, we can perhaps send out the CME from Stanford as an email to everyone so people can sign up. That will be easier for them. Thank you very much. Thank you, Linda.
Thanks so much.
Bye.